Hi, my name is Mac. I'm really happy to be here. Thank you for having me. Um, so today I'm going to talk about non-forced care in long-term residential care for people with dementia. Um, yeah, I wanted to acknowledge all of the people that are a part of this team and a part of this project. Um, and also say thank you to the participants for all of their contributions and also for being so welcoming and appreciative of our work. Um, and then thank you to those who have funded us. So this was a multi-jurisdictional comparative study of violence in home care and residential long-term care in Manitoba and Nova Scotia. Um, the project itself had 5 phases of data collection, which were document analysis, provincial surveys of violence in home care and in long-term care, remote interviews, digital diaries, and observations in long-term care facilities. So my part of the project and what I've been working on focuses primarily on observational, interview, and policy data, which were collected from a behavioral unit in a long-term care facility that has implemented a non-forced care policy. So that essentially restricts the use of force in daily care provision. The policy itself was developed in 2014, and to date, it has maintained efficacy in reducing staff injury and improving quality of care. So the non-forced care policy really emerged in response to the high risk of violence that exists in long-term residential care. Both workers and residents are at a really high risk of experiencing violence, and preventing these situations is especially complex when caring for individuals who have advanced dementia. Daily care practices can be especially challenging just because they can be so intimate and personal, and really require getting into someone's personal space. Um, and when care that workers feel is necessary and needed is declined, forcing care on that person can cross the line into abuse. And non-forced care policies kind of respond to this risk and acknowledge the risk of abuse to residents in those kind of daily subtle interactions. So this is a quote from one of the people who were in leadership in the facility, kind of describing the experience that led them to develop this policy and sort of the state that they were in beforehand and how they were in a spot where they really did want and need to make a change. So person-centered care values seem to be the foundation of non-forced care. So that really means like honoring people's autonomy and recognizing the enduring characteristics that exist within a person that maintain throughout the course of the illness. And also just recognizing the innate value of people's lives. It prioritizes really empathetic and relationally focused care. And it became really clear in interview and observational data that the care that was provided in the behavioral unit was really based in that real empathy and how to focus on building trust and building relationships, and then maintaining those relationships and trust. So this analysis really explores those alignments, both with person-centered care in how the policy came about, and then also how it was maintained. And we suggest that some of the important nuances in the way that non-forced care policies are put into practice make it more akin to a harm reduction approach to violence. So we observed a much slower pace in care on the behavioral unit, and we observed that staff really have the time and autonomy to build rapport with residents and negotiate care provision. This really represents an essential tenet of person-centered care, which is like building relationships with the person and really getting to know them. And then being able to respect their individual preferences because you know what they are, because you've taken the time and you've had the opportunity to do so. Really rigid and task-oriented daily schedules in other facilities can set up situations where it's almost necessary to force care. Participants in this facility really emphasized that checklists weren't as important as ensuring a sense of safety and security in staff and in residents. So the culture and environment of the facility were also really crucial in ensuring. This meant that care providers weren't seen as having failed if they weren't able to get a test done and if things were left undone because the resident had declined. The expectation of staff in the facility were more that care providers focus on providing care by building trust and honoring autonomy and respecting residents' decisions to decline care. I also wanted to make a note about the top quote that although it is a really meaningful respect, that some residents didn't want people entering their room. So it's accurate to kind of the environment, but there was also a real respect for people's preferences in that kind of way and wanting privacy. So from what we really understand of the policy and of the facility itself, implementation really began with a paradigmatic shift on a management and policy level that was really inspired by a real desire to take a more humanizing approach to care. The culture and the structure of the institution itself, specifically the behavioral unit, were really conducive to change because they already had higher staffing levels and they had good staff retention. With the implementation of the policy, the expectations of staff changed. And with that came a need for a higher level of interpersonal and relational skill in order to effectively negotiate care. We observed a really high level of skill in care provision in this particular facility, as well as that slower pace. And what was also interesting was that in some cases, we observed that residents felt really empowered to assert their bodily autonomy and decline care or assistance, but in a way that seemed really respectful. And what seemed to be important in the success of the policy here was the commitment that leadership maintained to improving care and having that mutual trust and accountability between staff and management in care and between staff as well. What we also noticed was that there was an interesting distribution of labor where management still considered themselves to be care workers and still provided daily and bodily care to residents. And housekeeping staff were involved in shift change meetings. So we're part of the discussion about what had gone on in the previous shift and how to make sure that the residents were being effectively cared for, and what had happened during the last few hours was something that people were all aware of. It just seemed very, very equitable. And it also felt like people really looked out for each other. Leadership described a very strong team environment in their interviews, but it became really apparent in the observational data. So in this quote, a leader in the facility kind of describes the catalyst for their decision to find a new way to provide care. So this really represents that better and change the way that care is provided. Residents and staff deserve to feel safe in the place where they live and work. And by kind of assessing how care had been provided in the past and basically in like their cognitive capacities and the way that they would experience the world, healthcare workers were able to kind of conceptualize forced care as a form of abuse. And they kind of explained to us how forcing a resident to change their clothes and forcibly taking their clothes off would almost be experienced like a sexual assault and could be really traumatizing for them. They placed a lot of importance in building relationships and building trust, but in the past. We also noticed that residents' capability to make decisions for themselves by declining care was respected. And so this sort of mindset shift is really important in honoring personhood and autonomy and their experiences, rather than just dismissing behavior almost as meaningless. Um, the participants in this study explained to us that when it seemed really stressed or agitated, they focus on trying to figure out and investigate what might be causing it. And that in a lot of cases, controlling pain is really important in ensuring quality of life, but also making sure that the non-forced care policy is possible and instead of an antipsychotic, and described how being in a lot of pain can cause delirium and how that can cause symptoms, and kind of looking a little bit under the surface. But even looking at that, the non-forced care policy was able to reduce their use of chemical restraint just by making sure that with higher staffing levels and then also improving staffing levels, that they had the time to figure out what was going on and how to reduce agitation without using a chemical restraint, and therefore preventing violence within the facility. So in interviews, staff explained that some families found the transition into non-forced care really challenging. They wanted to see their family member clean, and then also they struggled with the fear that their loved one wasn't getting the care that they needed, and yeah, that they weren't being cared for effectively. And this was really remedied by open communication with family members and building trust and connection between the staff and management and the families. Families' concerns weren't entirely unreasonable because there is a potential for staff complacency with non-forced care and with a policy where if someone refuses care, your role is to allow that to happen. There can be a potential for neglect, and fears of neglect aren't entirely unfounded, even though that was not something that we saw in the observational data. But I think that it's important that managers are able to trust that their staff are capable enough, but also care enough to take the time to be creative and problem solve and recognize nuance and interactional subtlety and really try to provide care. This also means that staff need to be able to recognize when they're crossing a line into force and being aware of their behavior and the impact that it's having on the resident. So we found that because of this, care providers were constantly navigating a sort of gray area between care and abuse and providing care effectively without violating a resident's boundaries or breaking their trust. Non-forced care policies, like I said, can generate those concerns about neglect, but in practice, non-forced care requires frequent and in-the-moment evaluations of the risk of forcing care against the risk of going without. So keeping in mind the risk of neglect and the risk that can be associated with not providing care, it's about understanding what the risks are and how to mitigate them and how to minimize them. We notice that workers can and do push boundaries in some situations, and that non-forced care can involve deception, manipulation, repeated requests for care, occasional use of chemical restraints. But that being said, their practice is still aligned with the values that led them to implement the policy to begin with. So it was really about a promotion of mutual respect between staff and residents, and then also between staff. It can kind of be seen as harm reduction rather than the complete absence of forcing care. And even just thinking about that, I'm reminded of an interview where a staff member said that they're kind of trying to figure out whether or not this is the sword to die on. And they describe situations where
I
they're
need to sign up
assessing. Sorry, what was that? Okay. Yeah, so they're assessing basically, really assessing risks and then also looking at the impacts of what's going on other residents. So an example that was used pretty frequently was if a resident has fecal incontinence, that has the potential of degrading the resident's skin and making the space really unpleasant and unsafe for other residents and also for themselves. And so in that case, they described feeling like they needed to be more firm with care and not necessarily use overt restraint, but in some cases be more firm and more forceful to kind of ensure the safety of the residents and themselves. So it really came down to genuinely thinking about the spirit behind the policy rather than the policy itself. So it is a non-force care policy and it does restrict the use of force in care provision. But at the same time, it's more about honoring the values that were underlying the policy. And then the policy itself seemed to make it so that it was at the front of people's minds that forcing care shouldn't be happening and that it should truly be a very, very last resort. And that other things should be considered every time. Like I said, evaluating sort of what's going on for the resident and what their experience is and what could be causing whatever behavior is happening. It just took a level of skill that we noticed within staff, and that seemed to be reproduced through the policy and then also through communication with each other, like learning how to implement the policy, learning how to be creative and find those situational nuances and get to know residents in a way where you know which boundaries you can push and when you can't push boundaries, and really understanding the situation and understanding the people that you're caring for and building a strong team environment where you're communicating and making it so that you're looking out for everyone in a sort of connected way. So yeah, I think that what's important to note is the importance of the facility culture and environment in supporting staff, but also the importance of the high staffing levels that they had in this particular unit. They really had time to build relationships with residents, and they had time to build relationships between staff and created a more relaxed environment where it didn't feel panicked and care didn't need to be forced. And I think that that is incredibly crucial to recognize in the promotion of non-forced care, is that what enables it to be effective is those high staffing levels. And without adequate staff to carry things out, the environment isn't the same. There isn't the same level of comfort and isn't the same opportunity to build relationships. Again, what was really important was that it really had that paradigmatic shift where the entire mindset of the facility and the institution changed in a way that could guide the way that care was provided beyond just what was being written down in policy. So because of the trust and accountability that existed between managers and staff, and because managers trusted that the people that were working for them cared enough and were capable and had the skill level to use that creativity and to figure out the best way to provide care and to ensure resident safety, because they trusted them to be able to do that, and because they had that kind of accountability where staff believed that if they didn't force care and if care tasks were left undone, that they wouldn't be punished for it. Because there was that safety within the institution, the residents were able to also be in a space that was safer and more respectful. So essentially, it created ways to be collaborative. and collaborate with residents, understanding their needs and understanding what they want and understanding what their preferences are and what experiences that they'd had in their life that led them sort of to the spot that they're in now. Leadership at the facility also mentioned that past experiences and traumatic experiences can really influence the behavior of residents and also what they're adverse to in care. And being aware of that really ensures that staff are humanizing the resident and treating them like a person who's had an entire life full of experiences that have built them and that influence who they are now and what they need. So really involving everyone in the process and respecting all people that are involved in care, including the families of residents and residents themselves, made it so that harm could be mitigated in situations where harm can seem almost inevitable. And in situations like have been described or that I've seen described in other interviews from other facilities where it feels like you're stuck kind of between two bad places and two bad options. In a lot of cases, when people are forcing care, they do recognize that they're contributing to the aggression that residents can show during care. So that responsive behavior, like having multiple staff in the room while providing care and holding someone down and using physical restraint, and behaving in a way that the resident might find really frightening. And even though that's done in order to protect staff from being injured, it also contributes to the aggressive behavior itself and contributes to a really vicious cycle of staff being forceful in care and residents being aggressive in response, and then staff using further restraint in order to avoid injury. And in this case, the facility really looked to break that cycle and change their own behavior and change their own norms so that they were providing care in a way that wouldn't necessarily inspire as much aggression and that kept residents safe and made them feel safe in their home. And yeah, finally, I think what's most important is acknowledging how complicated care provision can be, especially navigating consent with people with cognitive impairments and navigating consent around care, and then also figuring out when things have gotten to a point where it's necessary to intervene and recognize that the person might not be able to make the best decisions for themselves and do so in a way that is respectful and respects their humanity and their needs and also is provided in the least forceful way. There are a lot of ethical dilemmas around force. It can be really complicated to figure out what the best course of action is and what option that you should take. And I think that really acknowledging that and acknowledging that it's difficult and that problems in navigating care can't necessarily be entirely solved by a change in policy, even in such a big change in policy, and that it takes more than that. It takes staff education because staff were continuously being educated with training like pieces training, and then also adequate staffing levels. Looking at more than just policy is really crucial in understanding how to make positive change, because like I said, policy wasn't necessarily followed to a T, but the values behind the policy were. And looking at that and acknowledging that it's difficult and acknowledging that following policy perfectly might not necessarily be entirely realistic can encourage higher standards of care and also encourage those trusting relationships between management and staff where, like I said, where they're trusted to make almost executive decisions and navigate the situation the best that they can. So yeah, I'm happy to answer any questions.
Thank you so much, Mac. Yeah, so floor is open if anyone wants to turn on their mic and their camera, or pop a question into the chat if you have anything that you would like to know more about or clarify, or just any information to share or ask of Mac in response to this great presentation.